Wow.
Oh, don't mind me if everybody else wants to. Because I didn't even know. No, I said that. Oh, I mean, I thought you meant like you had to be like 6 or like. No, everybody. No, everybody. I don't know.
All right, so we'll get started with class. And you'll take the exam at 3:30. So the piece of paper that I gave you, you'll write notes on there and draw some pictures. So we want to go through graphical analysis on the vented patient, and it kind of ties in with asynchrony of a ventilator patient. Like, how do you know if you're ventilating correctly and causing the least amount of problems with how they're breathing with the ventilator? And then the second part is going through ventilating a patient who has COVID-19 or the SARS-CoV-2 virus. So the first one on your paper, it says, do we have adequate flow? And what you can type into your notes is that if you're trying to figure out if you're giving enough flow to the patient when the air is going in, you want to look at your pressure time graphic. If the pressure dips during inspiration, there is not enough flow. Yes. You're welcome. Thank you for saying something. Yeah. You wish you knew it last night?
So on Friday, I was tested on this and I was just blanking out.
Oh. All right, so now to draw what that looks like when you're looking on your graphic. So in a volume mode of ventilation, we know that, let me look at the graph here. In a volume mode of ventilation, pressure builds throughout inspiration, then the exhalation valve opens, and then the pressure goes back down to baseline, whatever it may be. Volume. But if the patient's breathing in faster than you are delivering the air, you won't see that nice climb in pressure. What you'll see is kind of like a slower climb. And then at the very end, it goes up. So does that kind of look like a scooped out appearance or something? So word-wise, we would say, oh, pressure doesn't build throughout inspiration. But if you're drawing it, that's what it would look like. It could be extreme where you know, the patient's breathing in, they're trying to get some air, there's just not enough air coming in. And then at the end, they kind of give up and then the pressure goes up. So all of that indicates not enough flow during inspiration. Okay, the next one is Do you have adequate sensitivity? So again, you would look at your pressure time graphic. If pressure dips below baseline, if pressure dips below baseline at the start of the breath, the sensitivity is not sensitive enough. And how do we draw that? So we see that, let's say there's 5 centimeters of PEEP set, and then the patient inhales and they generate enough negative pressure, and finally the ventilator kicks in and gives them their breath of air. So if you have pressure sensitivity set, you want it to be set at usually -1 centimeter of water, so they don't have to have a lot of effort. And then if it's flow by sensitivity, the two servo ventilators are different from each other. So servo I and servo U. So the servo I, you set flow by for the sensitivity by setting it between number 1 and number 10. And the servo U, what do they have? 1 liter per minute to 2 liters per minute. So if you're setting, if you see on the graphics that the patient is having a hard time initiating a breath, and you have your flow by sensitivity set at number 2, what could you do to make it easier for them to initiate a breath? Change it from 1 2 to 1 to make it easier. Now think of the servo I. Yeah, servo I goes from number 1 to number 10, and there's no units. So if you're at number 2 and it's hard for the patient to initiate a breath, what could you do? Very good. So as the numbers go up, it gets easier to initiate a breath. So if number 2 is difficult, then you would go to number 5. On the servo U, it's pretty much liters per minute of flow that the patient has to move to initiate a breath. And they don't give you much of a range. I think it's 1 liter per minute to 2 liters per minute. So which one would be easier for them to initiate a breath? The 1 liter per minute. So less flow would initiate a breath. Oh, I see. Okay. All right, then we'll move down to hold on 1 second, guys. Okay. What does turbulence flow look like on the graphics? Artifact, okay. Like, oh, I can't do squiggly with the mount with a.
It looks like you do.
How's that? So squiggly lines is what I call it. Or wavy lines in the pressure time graphic. Indicates either water in the circuit or the patient could have secretions in their upper airway. If there's a circuit leak, what do you look at on the ventilator graphics to tell that you have a leak? Okay, so the volume time graphic. So the air goes into the lungs, but not all the air comes back out of the lungs because there was a leak somewhere. And then it just goes like this until it's time for the next breath. The ventilator will reset the graphic and then deliver the next breath. So you're look on your volume time graphic, and if the volume doesn't come down to baseline, there's missing volume. Over distension. So let's say we didn't do the 6 to 8 mLs per kilogram ideal body weight tidal volume. And the patient's put on a tidal volume and they're in a volume mode. So let me add that to this. It's noted on volume modes only. So if you're in PRVC or pressure control, you're not going to see this. Do you know what I'm going to draw before I draw it? Yeah, all right. So pressure's building throughout inspiration. And then all of a sudden, a lot of pressure builds trying to squeeze in the last little bit of air. And you get a duck's beak, I guess it's called. So that extra pressure stretch, when a little bit of tidal volume is going in, it's called beaking, I guess, or over distension. Yes. Duck beak on a hysteresis curve. Can you see this? Will this show up in a pressure mode or PRVC? No. All right. How do you look at changes post bronchodilator? You will look at your flow volume loop and you will check your expiratory flow rate. So flow volume loop. So which of these shows the worst expiratory flows? Yes, so number 1 or number 2? Yeah, number 2. So this is a low flow. Next, we're looking at air trapping. And to see air trapping, look at the flow volume loop. Nope, I said it wrong. Flow time graphic. Air goes in. Air comes back out. Air goes in. Air comes back out. All right, so I drew 2 breaths. Of the 2, which one shows air trapping occurring? Number 1 or number 2? Number 2, very good. So as the patient is exhaling, there's air still leaving the lungs, and it keeps that way even after the next breath starts. So if it's not touching baseline at the end of exhalation, we have air trapping occurring. How would we measure that? Expiratory hold, very good. Okay, so that kind of answered our next one. For auto PEEP, you would do an expiratory hold. PEEP tote, yes. Yeah, that's true. Did I erase that too soon? Let's see, are you drawing the flow not back to baseline? Oh, okay, I'll give you a second. All right, so we're looking at the hysteresis curve. We noticed that a lot of pressure builds up, not much volume is going in. And then all of a sudden, volume starts going in. So what has happened is the pressure popped open the alveoli, and now the alveoli can fill with volume. So now we actually have air being delivered into the lungs. What can we do to fix this? Very good. If we set the PEEP at the lower inflection point, that'll keep the alveoli open all the time, and volume will start to go in as soon as the breath is initiated. Okay, and then double cycling, do I have that on your paper?
Yeah.
Oh. So double cycling occurs when the patient wants a bigger breath of air than the set tidal volume. So the patient gets their tidal volume, and they're still breathing in because it wasn't enough to satisfy them when they were breathing in. So what'll happen is the volume gets delivered and they breathe in and they get a second tidal volume delivered right away. So let's do this on pressure. Let's say it's, I guess I did a pressure control breath. So you don't see any exhalation occurring. There's a breath and then there's another breath. So that's pressure control. And then in volume, the volume is climbing. And then another volume goes in and then they exhale. So it's, I don't think I drew that right. It's like one and then another right after it. I don't get a choice to erase. Oh. So pressure builds up as the breath goes into the lungs. It's not enough. The patient wants more. They breathe in and initiates a second breath. So that's called double cycling. To fix this in a pressure control breath, you can just set the I time to be longer. So I wrote, if you're in pressure control or in PRVC, you can fix this by setting a longer I time. Have you come across that at all on your patients? You did? And it didn't help? What mode? Oh, really? So if PRVC wasn't working, switch over to pressure control and now it's working. Very good. So you understand that. Oh my God, I'm so proud of you guys.
My patient was like neuro breathing. So they were, I had to like fiddle with the eye time and then that still wasn't helping right now. The respiratory rate was like 35.
Amazing. Wow. Pressure support helps also. There's no backup rate, so once they sedate them, that's a problem. But oh, okay. Yeah, pressure support is much more in sync with what the patient wants. So everything kind of works out. They get the tidal volume they want, they're more comfortable. But yeah, I can see how pressure control helps too. Okay, so that was that sheet. And now for the PowerPoint. Yes, ma'am. Okay. All right, let me write myself a note. Yeah, a student from last year was telling me the same thing, Jason. He kept saying, oh, can you put up the PDF? But for me, when I download the PowerPoint, then it opens up normally. Instead of, oh, so we're so used to saying COVID-19, and I just wanted to refresh my memory as well as your memory. The actual name for the virus is called SARS, severe adult respiratory syndrome, CoV-2. And a lot of people say CoV-2. So that's the official name of the virus, and we all just say COVID-19. And it comes from the coronavirus family of viruses, which are common viruses, apparently, of, getting the common cold. But COVID-19, not so mild. So different methods that reduce the transmission of the virus. It says already discussed, but I don't know if this was already discussed with you. As far as what to wear for PPE when you're going into a COVID-19 isolation, you wear everything? And face shield, very good. You had a COVID patient? You did? Wow, okay. So you had to wear goggles and a face shield, or just the goggles? Wow. So did you feel not as protected as the therapist, or you felt okay with what you had on? Okay. Why would the patient with the virus be placed in a negative pressure room? Airborne isolation, yes. So the virus supposedly travels up to 6 feet. When a person coughs, it can travel up to 6 feet. And then it lands on a surface. But because people were still contracting the virus, then it was thought, well, maybe 6 feet isn't good enough. Maybe we need a negative pressure room, because maybe the virus is staying stable in the air for longer than we imagine. What is another contagious infection that needs a negative pressure room? Tuberculosis, very good. So that's a real stable particle, and it's less than 5 microns, and apparently it can travel pretty far, and somebody can inhale it. All right, as far as placing a patient who has hypoxemia, COVID-19, their SATs are low, should we place them on a high flow nasal cannula or put them on non-invasive ventilation? High flow? Is that what you guys were taught already, or you don't know? You don't understand the question? So the high flow cannula develops a little bit of positive pressure with it. And then of course, increased amounts of oxygen, you're heating and humidifying the air, and then they breathe it in. So it helps with hypoxemia, it helps a lot. Or you can put the patient in non-invasive ventilation and BiPAP, where you set an IPAP and an EPAP and help their work of breathing during inspiration. Oh yeah, and then add your expiratory filter on the exhalation port. Yes.
Which is better for-
So they're, I don't know if it's biased studies, but they're showing high flow cannula is better than using non-invasive ventilation. But that information came from, was it Fisher-Paykel? And the OptiFlow, that's high flow nasal cannula. So when they put out studies, should I really be quoting them? But they're claiming that patients didn't need intubation as much if they were on a high flow cannula compared to needing non-invasive ventilation. So I guess if you're going to a high flow nasal cannula, I know I am, I'm already making the assumption that a nasal cannula, a regular nasal cannula was not getting the O2 sats up to 90%. Non-rebreather was not getting their sats up to 90%. So now how are we going to oxygenate? Do we go right to BiPAP or do we try high flow first? High flow is next and then BiPAP. Yeah. Yes, yeah. So yeah, high flow, non-invasive, and then intubation. And then the question is, does high flow spread the virus into the atmosphere as much as non-invasive ventilation does?
Yes.
Okay, so on BiPAP, you can add a filter to the exhaled air, but what about the leak around the mask? The goal would be to reduce the amount of virus in the atmosphere, I guess. Because if you're next to the patient, even though it's a negative pressure room, they can still be putting the virus into the air. So they're showing high flow nasal cannula with the patient having a mask on their face, like a surgical mask. All right, so I don't have any hard and fast answers for this. But because of the high flow, it does put the virus into the atmosphere. And then for intubation, the best intubation methods, how can you reduce exposure to the virus during an intubation? Would direct laryngoscopy be good, or what about using the glide scope? You vote for the glide scope? Yeah, do you know why?
You visualize it faster.
Yeah, and you're right, you don't have to have your face right up to their mouth to see. Now you're just holding it and looking at a screen, so you have a little more distance from you to the patient. And what about bag mask ventilation prior to intubation, after intubation? So that's frowned upon. Like patients in distress don't pre-oxygenate with bag valve masks because you're putting too much virus into the atmosphere. The thought is go right from they're wearing high flow or non-rebreather mask, take that off, intubate, and then don't bag, hook them up to the ventilator because the ventilator has the filters in the circuit. So all the air will go in and out of the ventilator and in and out of the filter. So you're not putting a lot of the virus into the environment. And then patients that are COVID-19, giving them a nebulizer treatment. They breathe in the aerosol and they blow out the aerosol. And now they can have suspended virus on those aerosol particles and it spreads throughout the room. So they were changing that to like MDI, trying to avoid giving COVID patients a nebulizer treatment. So when you place a COVID-19 patient on the ventilator, it says connect to the ventilator as soon as they're intubated instead of bagging. So that's because the circuit has the filters. Keep the endo tube occluded with a finger and immediately attached to the ventilator circuit. And typically the intensivist does that. So, you know, they put the tube in, take the stylet out, and they put their thumb over the tube, and they want the ventilator circuit to attach it. Does that make sense to you? Like if you see them occlude the tube, you understand why they're doing it? Okay. You want to have the ventilator prepared ahead of time, have it on, have settings entered. So as soon as you connect, you would go from standby to ventilate. Use a HEPA filter on exhalation. That's a given, right? And then for extra precaution, you can use a HEPA filter on inhalation. I don't know how that helps. Perform the pre-use check ahead of time with these filters already added. And then should you use an HME or should you use a heated humidifier? Probably better with heated humidity because you don't have to disconnect the circuit to change the HME. But if there is an HME in line, it's recommended that you change it less often. So I see them changing HMEs all the time on patients. Have you noticed that? If they get nasty, I can understand that, but go ahead. Oh, with COVID patients? Ah. Ah, okay. That makes sense. That helps a lot. You were going to say something?
Graduated from here, I just changing HME, but a lot of HME said that you're gonna start not change the HME classes to changing it. Professor Yvonne's gonna tell you I'm doing it wrong. So still gotta do it.
Why? Why do you still got to do it?
Because she says that they have, what we learn in class is different than we learn.
That was the reason?
Yeah.
Yeah, you could have done better than that.
Lane at regional, she told us not to, she told me, and I don't remember who else I was with, to not change that HME so regularly because it's dry if you keep changing it, and it's not humidifying the patient. So
Exactly.
it should be changed if soiled. I think that's just a practice that like routine, you go in the room, you do the vent check and you change the HME. I think it's just more of a routine, but it's not proper practice.
Perfectly stated. Yeah, so you want it to accumulate moisture. I mean, that's how it's providing humidification to the airway. And if you take that out, throw it in the garbage and put a dry one in, you're drying out the airway. And now the little cilia can't work and get mucus plugging. Yeah, in the HME, yeah. If you see a layer of water, that's going to create a resistance to flow. That you would change. But condensation should be there. Oh, and that's good. So do they understand what they're doing?
I think it's routine, like,
Yeah.
it's routine, they don't wanna have to do it at a certain part of their shift, they're not thinking about,
What they're doing,
about what they're doing, it's just
a task.
a task, correct.
Yeah, I see. I understand. I disagree, but I understand. So in ventilator modes, what's the best mode of ventilation for somebody who has COVID-19 pneumonia? And it says that no mode has been proven to be better than the other. It's usually determined by the area in the country. So some use PRVC, I guess that would be here. Some people use volume control, ACVC. Some people use pressure control and some people use APRV. But when they gathered all the statistics, it came out to be the same mortality rate. So it didn't make a difference. Yes. Yeah. It says the goal with mechanical ventilation is to use gentle ventilation. This equates to using low tidal volume ventilation. And low tidal volume is considered 6 mLs on here. We learned the range 4 to 6 mLs per kilo, so that stays. Lung compliance is high compared with other etiologies of ARDS, but you want to keep driving pressures, and it explains what a driving pressure is. If you do an inspiratory hold and you get your plateau pressure reading, and you subtract the amount of PEEP that is set, you want to keep that between 12 and 15 centimeters of water. How can you do that? You can do it by adjusting the patient's tidal volume. So let's say you have them in PRVC and their targeted tidal volume is, I don't know, 400 ml. And you do an inspiratory hold and it shows 30 centimeters of water and they're set at 5 of PEEP. What is their driving pressure? Should I put that in the chat? Did I say 25 or 30? So a patient in PRVC is receiving a 400 ml tidal volume. You perform an inspiratory hold and the plateau pressure is 30 centimeters of water. The patient is receiving 5 centimeters water of PEEP. What is their driving pressure? Very good. It's plateau minus PEEP. Same thing you would use to figure out your static compliance. So if it's 25 centimeters of water, and what is this PowerPoint telling us to do? So we would want to reduce the tidal volume until it's 15, at least 15 centimeters of water. So plateau minus PEEP is 15. So if we reduce the tidal volume to deliver a smaller tidal volume, give more gentle ventilation, what's going to happen to the CO2 in the blood? Yeah. So if you're giving a smaller tidal volume, what do you have to do in addition to giving a smaller tidal volume? Very good. Did you get that, Chris? If you're turning down the set tidal volume, what's going to happen to the CO2 in the blood? And how could you fix that? Yep, good job. So you start with a faster rate. So we said, what, 12 to 20 is normal. You would start with a rate of 20 per minute. If you're increasing the respiratory rate and now you're more than 30 breaths a minute, what could be a concern that you have to look out for? Air trapping. And what about the IE ratio when you have a fast rate? It might be inverse ratio at that point. Yeah, so you have to make sure your I time is short enough so you don't have inverse ratio ventilation. So if the rate is above 30 per minute, ventilation. So if the rate is above 30 per minute, you may have to adjust the I time to prevent inverse ratio ventilation. Controversy over acceptable saturations. So the World Health Organization says to keep O2 sats greater than 90%. The Society for Critical Care Medicine says to keep SpO2s better than 92%. Happy hypoxemia in non-intubated patients. So initially, when all these patients had severe hypoxemia with COVID-19, they were getting intubated left and right. If we weren't getting their oxygen or their O2 sats, 90%, they got intubated. And then, of course, they ended up dying for a few days later. And then it was thought, well, their sats are low. What if we just leave them for a few days and see what happens? And then all of a sudden, the mortality rate got better. So avoiding ventilation was a good thing, and just tolerating these low O2 sats. So Dr. Cohen was talking to us at the advisory committee meeting, and he called it happy hypoxemia, saying that the patients didn't feel short of breath, and yet their O2 sats are like 85%. So they just left them with that kind of a saturation, and they did well.
So it's similar to like a CO2 gear or CO2 retainer. It's okay to see that 80%.
Yeah.
They're still breathing on their own versus you intubate them and they're at 85 and they just stop trying.
Yeah, that's a good analogy. Chris?
They were like this symptomatic, other than the stat, breathing okay. I'm like, you got COVID. And yeah, you're really sick, but you don't need to be in the hospital, you know. So if there was a 190 or even 580,
You're sending them home.
just monitor your saturation. If it gets any worse and you start feeling worse, have trouble breathing, then come in. They weren't in respiratory distress. We really had a while back, but we want to move that.
Oh, I see. It was triage at that point, wasn't it?
But what is it? What is the temptation after getting intubation? Because if they're still getting a good amount of oxygen from being intubated, why are they dying?
positive pressure, it overstretches the alveoli. Do you remember us talking about barotrauma and volutrauma? Once the alveoli get overstretched, it releases cytokines, and that creates more inflammatory mediators, and that's kind of what damages the lung tissue. It's all these cytokines and inflammatory mediators coming in. Pardon?
So like if they weren't in here before that, they were.
Yeah, so it made things worse, unless if you're trying with using gentle ventilation when you have them on the vent. But you're right, they can also get a secondary infection. How many patients end up with pneumonia after we intubate them? So they could have the virus and then get a secondary bacterial pneumonia after they're intubated. All right, so we'll stop and take a break. You're welcome.
Yeah.
All right, so we're talking about ventilator settings with a patient who has COVID-19. We went through the tidal volume, the rate, and now we're talking about Peep. So use the optimal Peep to prevent collapsing and re-expansion of alveoli. And they're recommending using higher Peep. And to them, higher Peep is when you use more than 10 centimeters of water. And then how would you know if you have too much Peep being delivered? Peak pressure would tell you if you have too much Peep. Blood pressure drops, yes. And Krinja, what did you say? Okay, so once you have the extra Peep plus a volume, it can over distend the lungs. Okay. And with blood pressure dropping, do you remember the optimal Peep when you monitor some things and you start going up on your Peep to see if you have enough Peep? Do you remember what you monitor? Blood pressure was 1. O2 sat, very good. So you're looking to see the O2 sats improving. That tells you when you have enough Peep to keep the alveoli open. And what about having too much Peep? What started happening? The blood pressure dropped. And do you remember? That was different than optimal Peep. But yeah, it's true that too much Peep can raise intracranial pressure. Tijin? 20 millimeters mercury? Okay, and I got it from our textbook. So. So you ask everybody and then you see. But even different textbooks will have different values, like Oaks always seems to have different numbers than I have, so it's kind of hard to say. So when the venous oxygen saturation is dropping, that tells you that you've got too much Peep and you're actually preventing the flow through the pulmonary capillaries, and your gas exchange is compromised. So it's when the venous saturation drops. And that was it. And then this came from Egan, chapter 48. And it lists different patient ventilator asynchrony. And it's a list, it's got something on 4 different slides. But I think it's familiar to you already. All right, so the first one is trigger asynchrony. So if a patient takes a breath in and the ventilator doesn't recognize that they're breathing in, typically this happens with auto Peep. When they have a lot of trapped air in their lungs, their inspiratory effort doesn't tell the ventilator to give them a breath. So that results in trigger delay. Do I put all this in the chat or is it sounding familiar? Okay. Yeah, for trigger delay with air trapping or auto Peep, the patient's effort is not noticed by the ventilator. Noticed by the ventilator. So you'll see them breathing in and they're not getting a breath, and that's why. We talked about double trigger. They want more tidal volume. So double trigger, they want more tidal volume. Mistrigger can happen when, again, they breathe in, the ventilator doesn't recognize it. That's kind of like the same thing with trigger delay. And then what is auto trigger? A leak in the circuit causes a breath to be delivered. So instead of the patient initiating a breath, some air leaks out the leak and the ventilator thinks, oh, that's the patient wanting to breathe in. Ah, very good. Yeah, and that initiates a breath. Yes, very good. So not only is it a leak, but also the sensitivity is set to sensitive. Look at this teeny tiny font. I think that's me trying to say a whole bunch of stuff on one slide, so it doesn't seem like a lot. So cycling asynchrony is how a breath ends. So with a breath ending, of course, we always want to try to line up with how the patient is breathing. So if they have a quick inspiration, we want to set our I time to be quick like they're breathing in. And if they're breathing in slow, then they can use a little longer I time. But if we don't set it correctly, what can happen? So here it says the ventilator inspiratory time can be too short or it can be too long. Okay, we know that. With pressure support, the expiratory cycling criteria percentage is too high. All right, so they're using different words than what I used in lecture. Do you understand what they're talking about? Yes, flow cycle off. If it's too high, it causes the breath to end way too soon. And if the percentage is too low, then inspiration is too long and it's not in sync with the patient. Okay, if ventilator inspiratory time is too long, it's corrected by, and then it gives you a couple pointers. The first one says decreasing ventilator inspiratory time in pressure control, pressure assist control or pressure SIMV. So basically using pressure control breaths to eliminate the pressure spike at the end of the breath. Do you want me to draw that?
Yeah.
Pretend that's a straight line. And we're in pressure control. So we know that the ventilator is going to keep pressure constant throughout inspiration. So when you see this constant pressure, but then at the end of inspiration, you see this pressure spike, that's the patient trying to exhale. So they need a shorter inspiratory time. Does that make sense? Because they want their I time to end like right about here, and it kept going. So it caused them to like push against it. And then it says increase expiratory cycling criteria percentage. So the breath ends sooner. And that would eliminate the pressure spike at the end of the breath. Oh, they're talking about a pressure support breath. If you see a pressure support breath like this, you want to set your inspiratory cycle off to a higher percentage. So how can you remember that? How about spike at the end of the breath? We want to end the breath sooner. Would that be good? Okay, let me write that in. If you see a spike at the end of inspiration, the patient needs a shorter I time. How do you get a shorter I time with pressure support? Tijan? Increase flow cycle off. Very good. Okay, and then the next one is talking about double triggering, increase I time to eliminate double triggering. We talked about that one already. Decrease expiratory cycling percentage. Okay, decrease expiratory cycling criteria percentage so the breath ends sooner. Will it end sooner? So that's got to be a typo. I mean, I took this from the chapter, but it doesn't make sense. So if you have a smaller percentage, your breath is going to be longer. Okay, here we are correcting the textbook. That's cool, right? Longer. The breath will be longer. So if our inspiratory cycle off, if we set it down to 10% or 20%, it's going to make the breath have a longer inspiration. So double triggering with pressure support, give them a longer I time. Okay. Next one. Flow asynchrony. This happens in volume ventilation, and I was telling you that's why volume modes of ventilation aren't as popular as pressure modes of ventilation. And a volume mode of ventilation, you're setting how fast the air flows into the lungs. And if you set it too slow, now the patient's not getting all the air that they need. So the tidal volume will be delivered very slowly, but they might want the tidal volume to come in really quick. So that's going to create asynchrony. So it says change to decelerating flow. How would that help? To give a lot of flow at the beginning of the breath? Yeah. So decelerating flow, you get a lot of flow when the breath starts, and then it slows down towards the end of the breath, just like with normal breathing. So that's a good thing. Then it says increase peak flow to greater than 60 liters per minute. Again, that's just delivering more flow to meet the patient's needs. Match the ventilator I time to the patient's I time. Do you like the last suggestion? Change to a pressure mode. Okay, I think this is the last one, right? Okay. At the top box, it says inappropriately set sensitivity. We talked about that. If you have it too sensitive, you get auto triggering. Not sensitive enough, you see a big pressure dip before inspiration begins. So we talked about sensitivity. The next one is inappropriately set PEEP. If not enough PEEP, atelectasis will induce greater patient effort. I don't know if I like those words, but okay, we get it. All right, let's go down. Problems with auto PEEP. It says causes missed triggering. Do you understand the connection between the two? Come on, guys, it's the last slide, I'm pretty sure. So when you have a lot of air trapping, the ventilator doesn't notice when you're trying to breathe in. Okay. When you're in volume control, you might not have enough peak flow, and that might give you an inappropriate inspiratory time. In pressure control, you might have inappropriate rise time, or your inspiratory time may not be set correctly. And the last one, we can't read it, and that's okay. We're done. We did it.